Good afternoon, ladies and gentlemen. We'll be starting again very soon, so could you please take your seats? Thank you.
Yes.
Yes. Dr. Soar, before we move on from the injury to Dawn Sturgess's brain, I'd like to ask you whether you still believe that the medication given to her for cardiac problems might have contributed to the bleed on her brain. So if I could just take you to your report, reference 5994, page 107, paragraph 42.
Sorry, page number?
107,
Okay.
paragraph 42. So this is in your initial report, of course, prepared before you had the benefit of those discussions with Dr. Minks and the CT scans, which we heard about before the lunch adjournment. And here at paragraph 42, you posit that Dawn had some additional factors that would have increased her risk of bleeding. And we can take them fairly quickly, but she had been prescribed dual antiplatelet therapy on admission, is that right?
Yeah, I'll just go back a step. So we said that increased risk of bleeding into an already damaged brain,
I see.
as opposed to just out of the blue.
Yes.
Okay, so she was on dual antiplatelets, yes, and they're given primarily if it's someone's had a heart attack and a blockage in a blood vessel, and they're given, so the dual antiplatelets are aspirin plus another drug, and in Dawn Sturgess' case that was clopidogrel, and they're given to unblock any arteries in the heart.
I see.
And one of the commonest causes of cardiac arrest is having a blocked artery in the heart. So it would be reasonable, especially because her first heart tracing showed some abnormalities that could be compatible with that.
I see. Can I take it from that you think that the treatment given to her, therefore, was appropriate in that sense?
Yeah, I think it was reasonable, and what would happen in it wouldn't be seen as outside normal practice.
So normal practice treatment, though in fact it also carries some risk of increasing the danger of bleeding, is that it? Into an already damaged brain.
Yes, in that, but this was started when she first came into the intensive care unit, and when people have a cardiac arrest and they've got an abnormal ECG, thinking that it's a primary heart problem's a reasonable thing, and starting them on drugs that treat that would be reasonable. And in the big scheme of things, in someone who's already sort of died once and you've restarted their heart, it's a relatively low risk intervention.
She was also receiving dalteparin, 5,000 units a day. Can you tell us a bit about that drug?
So all patients who get admitted to intensive care onto a breathing machine are judged for being at high risk of developing blood clots in their legs. And dalteparin is an injection that decreases that risk.
I see. And at paragraph 42C, you note that Dawn Sturgess had a fall in platelet count on the 5th and 6th of July. Is that right?
Yes, so platelets are what make blood clots form and make your blood clots more sticky. And her values dipped around the 5th and 6th of July.
I see. And actually, if we turn over the page, we can see, I think, the values, correct me if I'm wrong, but for her platelet count, is that right?
Yes, we're in very small print. So on the 4th it was 118, on the 5th it was 78, on the 6th it was 42. It quotes a normal range of 150 to 400, but anything over about 80, 100 would be okay.
I see.
Yeah.
Is it still your opinion that the combination of these factors increased her risk of bleeding into her already damaged brain?
When we discussed it with Dr. Minks, his view was that it was just a bleed into a dying brain, but the presence of these factors made her maybe bleed more than she would have otherwise. So they didn't cause her bleed, but made it a bit worse when it occurred.
Is it like giving, well, I may well be wrong, but people who are at risk of stroke, for example, are frequently prescribed blood thinners, aren't they?
Yeah. Although these drugs aren't necessarily strong blood thinners, these are all, the antiplatelet drugs are to stop the blockages in the coronary arteries and stop them getting worse. See, they're all relatively low doses.
I see.
They're not full anticoagulation, which is making your blood clot 2 or 3 times slower than normal.
I see.
Yeah, but even there, they're prescribed, presumably because the risk of not having it is greater than the risk of having it.
Yes.
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 And so, Dr. Soar, would you agree that in light of your discussions with Dr. Minks, it's now your opinion that this may have contributed to the bleed that she had in her brain, but that the bleed itself was caused by the hypoxic ischemic brain injury? Is that right?
Yes, so being a bit more precise, a hypoxic ischemic brain injury led to an area of brain to die that bled, and the presence of these factors made it bleed more than otherwise. So it would be a bit like if I had those drugs on board now, if I cut myself, it would bleed more than if I hadn't got those drugs on board. And it'd be, yeah, so it didn't cause the bleed, but made it worse.
Thank you. That's very helpful. If we can then move on from that topic. I'd like to ask you now, well, in fact, before we move on from that topic, did the brain hemorrhage, so the bleed, did that impact on the survivability of Dawn's condition?
In my opinion, no, because the extent of the global hypoxic ischemic brain injury was sufficient to have caused her death. And it was a consequence of that severe hypoxic ischemic brain injury that she bled.
I'd like to ask you now about the point at which Dawn's condition became unsurvivable. And in fact, that is a question for you, Professor Nolan, I believe, in the first instance. So we've established that Dawn died because her brain was injured by a lack of oxygen caused by the respiratory and then cardio arrest.
Yes.
But now I'd like to explore at what point exactly her condition became unsurvivable. And if we could pull up now, please, inquiry. Perfect, thank you very much. That's the reference is 5994, your first report, page 19, paragraphs 43 to 46. So here, Professor Nolan, I think you deal in the report with the point at which the condition became unsurvivable. Can you just talk us through your conclusions there?
Yes, so in our opinion, Dawn Sturgess's condition was, on the balance of probabilities, unsurvivable by the time she was assessed as being in asystolic cardiac arrest by emergency services personnel at the time they have arrived. And we put there 10:33. And by this time, in our opinion, she would, as we've been discussing today already, she would have been in cardiac arrest for at least, in fact, we've said at least 6 minutes, but it's almost certainly more than that, because I think we felt that, having listened to the audio, which we didn't have at the time we wrote this, that her cardiac arrest, on the balance of probabilities, occurred at around 10:20, or at the most 10:21. So that means she's been in arrest for at least 10 or 11 minutes at that time. And bearing in mind the cause of the cardiac arrest, which, as Dr. Saw has explained, was secondary to a respiratory arrest, so it was because of very low oxygen levels. After that period of time, even if you can restart somebody's heart, they are not going to survive the cardiac arrest because of irreversible hypoxic ischemic brain injury.
So at the point that she was found, that the paramedics attended 9 Muggleton Road, already at that stage, her condition was unsurvivable.
In our opinion, yes.
Yes. And so whatever treatment she had been given by paramedics and indeed by the hospital doctors, none of that would have made any difference to whether she would have survived or not.
That is correct.
Okay. If we can move then to the standard of care given to Dawn at the scene and at the hospital. And whether there were any unreasonable delays in treating Dawn Sturgess for Novichok poisoning. That is our final topic for this afternoon. In summary, you conclude that the standard of care given to Dawn was reasonable, both pre-hospital and hospital. Is that right?
That's correct.
Dealing first with pre-hospital care, we heard evidence yesterday from a pre-hospital care expert, Mark Faulkner, about the standard of care that was given to Dawn Sturgess, so we can take this relatively quickly. It's addressed in your report, and can we pull it up, please, at page 108, paragraphs 45 and 46. So Dawn Sturgess had the cardiac arrest prior to the arrival of the first paramedic crew. That's right.
That's correct.
Was the correct treatment at that stage to follow the Resuscitation Council guidelines for cardiac arrest to restart the heartbeat?
Yes, that's absolutely correct, because regardless of the cause of cardiac arrest, the appropriate thing to do is high quality CPR along with adrenaline every 3 to 5 minutes, managing the airway as required during that period of time. And from what we can tell from the information that we have read and heard, that is what was done.
Yes. And if the paramedics had known that nerve agent poisoning was the cause of her arrest, would treatment with the specific medicines, atropine, pralidoxime, the anticonvulsants that you told us about, would they have helped Dawn?
In our opinion, they would have made no difference because she had already been in cardiac arrest for several minutes at that stage, and giving either of those two drugs or both of those two drugs would not have changed the outcome. It would not have increased the chance of both restarting her heart and certainly not of restoring her brain function, which was already damaged.
Yes, okay. And just finally, once Dawn's heart was restarted, the treatment that the paramedics should have given would be to support her airway, breathing, and circulation according to the post-resuscitation guidelines. Is that right?
That's correct. It's really about maintaining oxygenation of the blood, maintaining a reasonable blood pressure to therefore ensure that there is adequate delivery of oxygen and blood to all the vital organs, particularly, of course, to the brain.
Okay. And those, according to the material that you've considered, those actions were taken by the paramedics. Is that right?
They were indeed, yes.
Okay. If I can move on then to hospital care. One aspect of the instructions given for you to complete the report was whether or what symptoms of nerve agent poisoning or organophosphate poisoning the clinicians treating Dawn should have been aware of. But I believe this morning you gave us an answer, and please correct me if I'm wrong, that you would expect a clinician not to know necessarily off the top of their head the specifics of the treatment because it's such a rare presentation, if I can put it that way.
That is correct, yes.
But you would expect a reasonable clinician to know where to look for the information, for example, on Talkspace.
Yes, indeed.
Or where to find the clinical guidelines, which are at Appendix 2 and 3 of your report.
That's correct.
Okay. And just to complete the circle, in this case, it was, of course, Dr. Stephen Jukes who treated Dawn when she arrived at the hospital. And his evidence was that he himself was actually involved in the treatment of the Skripals, and that he was one of 5 or 6 intensivists at the hospital at the time, and that they shared their knowledge about the treatment of the Skripals.
Yes.
And that he attended some of the clinical advisory groups in any event. So Dr. Jukes' state of knowledge would be, would you agree, greater than your average intensivist?
I would say he was probably been one of the most knowledgeable intensivists in this country at that time for that topic.
Yes. Now I'm going to ask you in a bit more detail about the care given to Dawn. If we can begin at page 113 of your report, paragraph 19. We don't need to pull it up. It's just for Professor Nolan's reference. So here in your report, you're considering the treatment that was provided to Dawn during the period of the 30th of June to the 2nd of July,
Yes.
sort of the crucial period, if I can put it that way, when she first arrived, and when the diagnosis was uncertain. And at paragraph 19, you set out the treatment, you say, followed certain principles. Can you just elaborate on that?
Yes, so the principles for treating any person that has been initially resuscitated from a cardiac arrest are really to follow, well, the most appropriate guidelines would be the European guidelines for post-resuscitation care, which both Dr. Saw and myself were involved in writing.
Yes, I think, in fact, you cite the guidance that you and Professor Saw are authors of.
Yes, that's right, along with colleagues from around Europe.
Yes.
So these are opinions based on the best evidence we have for how to support a person after a cardiac arrest and increase their chances of survival and survival with a good quality of life. And that really means, the best way to summarise it is really to optimise everything. So to optimise the amount of oxygen in the blood, to optimise the blood pressure and the blood flow circulating around the body, to make sure the body is properly hydrated and is getting nutrition, and to really observe and survey for risk of infection, for example. And all of those treatments would be appropriate almost regardless of the cause of the cardiac arrest in the first place. There would be some individual treatments depending on other causes, but in this case that would have been the appropriate thing to do.
Yes. And so this sort of general supportive treatment, if I can put it that way, with which you're very familiar, having written the guidelines. Is that the treatment that Dawn received, and was it appropriate?
Yes, from what we've seen of the documentation that we read and the statements that have been made, it's entirely consistent with that. And it was clear in our opinion that the clinicians treating Dawn Sturgess were aware of those guidelines and had in their minds the sort of targets for the treatment that they were dealing with, as well as the secondary issues around the possibility of Novichok later on.
Yes. Well, if I can then move on to the differential diagnosis, Dr. Jukes gave evidence to the inquiry, and he explained that he had in mind 3 options.
Yes.
At the beginning when Dawn was admitted. And those options included possibly an intracranial bleed, he thought could be a cause.
Yes.
A low potassium level, because he said that would interfere with the heart's functioning.
Correct.
And also a drug overdose or possible anaphylaxis to do with the medication she was reported to have taken before her collapse. Do you agree that those were reasonable options for Dr. Jukes to consider when Dawn Sturgess was admitted to the ITU?
Yes, no, I would agree with that. I think particularly the possibility of some form of intracranial bleed or bleed into the brain as a cause, because she did have a headache preceding this, apparently. And so that would definitely make that a number one until such time as a CT scan had ruled that out, which it did. But all the other options are there. And I agree with him. It is slightly odd that the potassium was that value. That's only just below normal, but in the context of what had happened to Dawn, I would have expected it to have been much higher, as indeed was the view of Dr. Jukes.
Yes. We've heard a little from Dr. Soar about the treatment that she received in case there was a prime cardiac reason. We know there was also a 12-lead ECG conducted, there was one to her brain, but one to check the functioning of her heart, and that showed T-wave inversion and a possible coronary artery disease.
Yes, that's right. So this is ECG as opposed to EEG.
Ah,
So
I
it's an
see.
electrocardiogram.
I see.
And indeed, it is actually very abnormal. It shows across many of the leads what I would call deep T-wave inversion. So it's a completely inverted wave. And that would definitely raise suspicions of a cardiac problem, possibly, as Dr. Sturgess said, blockages in the coronary arteries. And so starting that dual antiplatelet therapy would have been very, very reasonable.
Yes, okay. Well, if I can take you just briefly to the medical records. The reference is 00130. Pages, if we begin on page 3. Yes, so these are the medical records for Dawn. And we can see just at the bottom there, we've considered them already with Dr. Jukes, so I'll take it quite quickly. But at the bottom, we can see this is the first entry by Dr. Jukes at 17, I think it's 40, on the day, on the 30th, when she was admitted. Now, I find them difficult to read, but you've distilled them actually in your report. I should mention that, sir, for your benefit. There is a helpful summary of the records at the beginning of the experts' reports. But you say that Dr. Jukes notes at that stage that she continued to have bradycardia, she was dependent on oxygen, she had hypothermia, a nasogastric tube was inserted. Yes, if we could just scroll down to the next page. Yes, there we go. We can see that there's the risk of refeeding, he mentions. She was to have cardiac arrest support. We've heard about that. Dr. Jukes was of the view that they should avoid hypothermia in her case because of the strain on her heart. And then if we scroll down the page, we can see at 6 p.m. an entry by Dr. Mortier, who we've heard is the specialist registrar. And Dr. Mortier records what we think is a conversation between Dr. Jukes and Dr. Mortier about ongoing bradycardia and a large amount of saliva on admission, pinpoint pupils and diarrhea, most likely not to be of significance, but noted. Drawing back to the evidence we heard at the very beginning of the day about sort of wet toxidrome, do you think that this discussion between the doctors treating Dawn should have triggered at that stage consideration of organophosphate poisoning?
In my opinion, reading this, I think it's clear that they were a little bit suspicious, so that they picked up and identified that as an issue. Bearing in mind that Dr. Jukes had been involved with the treatment and management of the Skripals early on, he would have been very alert to this. So it's my opinion that they parked that for the time being. They continue to treat Dawn in the way that would have been appropriate in any case, with all the things that we just mentioned. Mm-hmm. And then I think it was later on that day, the suspicion has been raised, and it wasn't, I don't think, that long after that when questions were starting to be asked about getting acetylcholinesterase levels done.
Yes, I think it was the next day. So Dr. Jukes, on the next day when he returned to the hospital, and his evidence was that he kept an open mind, of course, but after seeing Charlie Rowley's presentation, he was able to use the point of care kit to test for cholinesterase inhibition. One thing that I'd like to ask you about is this morning when we discussed the wet opioid concept, if I can put it that way, we discussed how secretions for somebody in a post-cardiac arrest presentation, somebody might have secretions because of pulmonary edema. but that sweating is something that you wouldn't expect. Having considered her records, there's no reference to sweating at this stage, but there is these secretions. Do you think, is that significant?
Well, in this particular circumstance, it should not be confused with pulmonary edema, because at this stage, Dawn Sturgess would have been intubated. She would have had a tube in her windpipe.
I see.
And on a breathing machine. So any fluid that was coming up from her lungs would actually come up through that tube. And so it would be fairly obvious that it was coming from the lungs, and shouldn't, under those circumstances, have been confused with saliva. So it seemed, in my opinion, they would have thought that was saliva, and I don't think they would have confused it with anything else. And I can only think that they, in their back of their mind, they must have been thinking about other things, but at that stage didn't have enough to pursue it. But it wasn't long, as I say, before they did, and particularly, as you've said, when Charlie Rowley was admitted with similar symptoms.
Well, before Dr. Jukes was able to observe Charlie Rowley's symptoms, a few intervening factors, if I can put it that way, were considered by him. Firstly, a police officer attended the hospital, that was Kerry Laws, and told Dr. Jukes about recent drugs intelligence connected with Charlie Rowley. In your opinion, would this be information that a clinician ought to consider when arriving at a diagnosis for a patient such as Dawn with an unexplained cardiac arrest?
So I think the information around drugs would have been relevant, although, as we know, that wasn't, in the case of Dawn, she was not taking drugs, but clearly, as I understand it, Charlie Rowley did have a record of drug taking. And so that must have been still high on the list of differential diagnoses, definitely. The question is what type of drug? Was there some contaminated drugs? And I know that was going through their mind as well. So that would have been part of their differential diagnosis. It had to have been.
Okay. One other intervening factor, if I can put it that way, that I'd like to ask you about is that Dr. Jukes' colleague, Dr. Russell, saw Charlie Rowley in the emergency department. And he reassured Dr. Jukes that Charlie Rowley was suffering from a drugs overdose. Dr. Jukes did not go and see Charlie Rowley himself at the time. So he was in the emergency room to begin with on the 30th. It didn't appear at that stage that he would be admitted to the intensive care unit. So Dr. Jukes didn't go and see him himself at the time. And he did not access the paramedic records either. If I can ask you two questions. Firstly, was it a reasonable action on his part, do you think, to accept what Dr. Russell told him about Charlie Rowley and not to go and see him himself?
So if I can speak as an intensive care consultant, where we often get contacted by our emergency medicine colleagues in the emergency department, we will often discuss with them cases, and in many, many cases, if their opinion is that somebody does not need to come to the intensive care unit, for example, it would be unusual for us to then, unless we were very concerned, it would be very unusual for us to then go down and still go and see that patient for ourselves. It would be different if the emergency physicians concerned were unsure and they wanted an opinion from us as intensive care consultants. That's very different. We would go down, review the patient, review the notes, possibly look at what had happened pre-hospital. But I would not have expected an intensive care consultant to follow that up if they were not asked to, and if the emergency physicians felt that person did not need admission to intensive care.
Okay. And now the second question that I'd like to ask you about is, Dr. Jukes told us that he was aware that the paramedics treating Charlie were concerned that this was a chemical incident, but he didn't know the reasons why the paramedics had that concern. Was it reasonable for Dr. Jukes not to speak to the paramedics or access the paramedic record?
I think it is reasonable on the grounds that he was reassured by his colleagues in the emergency department. And if that hadn't been the case, then maybe it would have been different, and maybe he should have followed that up. But I think it's very difficult, sat here with the great gift of hindsight, to comment on that. And in my view, I think if he was reassured by his emergency physician colleagues, then in my experience, I would not necessarily go and start chasing what had happened in the pre-hospital phase, partly because the emergency physicians typically have a lot more information about that.
Yes. Well, in this case, I can tell you that Dr. Russell had seen Charlie Rowley himself, in fact, and he was the CBRN lead. That was his position as a physician at the hospital.
So as an intensive care consultant with an individual with that experience and knowledge telling you that it's not anything other probably than a drug overdose, then I certainly would not pursue that further.
Okay. In your opinion, did the experience gained by staff who treated the Skripals enable them to diagnose and treat Dawn, Sturgess, and Charlie Rowley more quickly than they would have done prior to March 2018?
It was my opinion that they would have been able to make that diagnosis and appropriate treatment more rapidly, because they were the only clinicians in the country with the experience of having dealt with 2 cases in the last 3 to 4 months. And that's both doctors and nurses, and indeed all the team who looked after the Skripals. So in my opinion, they would have come to that diagnosis much more quickly. They even had the point of care equipment still available in the hospital to actually run the tests in the first place, which no other hospital would have had.
I see. And would you agree also that we've seen contact between Dr. Jukes and FT49?
Yes, indeed. The fact that they were able to actually have almost that personal contact, again, that no other intensive care clinicians would have been able to do. I think other intensive care clinicians would have relied entirely on tox-based information. And so they almost had a hotline in to people that really knew the subject very, very well.
Yes.
So again, that would have been a reason why, if anything, they should have been able to make that diagnosis more quickly.
Thank you. I'd now like to take both of you, in fact, to the conclusions that you set out in your addendum report. And they are at page 4 of document 5995. And I'm just going to read them out, and you can let me know if there's anything you'd like to change. And so the updated conclusions are, number 1, in our opinion, Dawn Sturgess's cause of death was a severe hypoxic ischemic brain injury following a cardiorespiratory arrest caused by Novichok nerve agent poisoning.
That's correct.
Yes, that's correct.
Number 2, in our opinion, Dawn Sturgess had a prolonged period of cardiac arrest that caused a severe, irreversible hypoxic ischemic brain injury caused by a lack of blood flow and oxygen to the brain. That meant that she would have died in hospital.
That is correct.
That's correct, yes.
Number 3, Dawn Sturgess had a brain hemorrhage during her intensive care stay that was a complication of her pre-existing severe, irreversible hypoxic ischemic brain injury. In our opinion, in her circumstances, she had no possibility of surviving to leave hospital. We note that a decision was made to withdraw life-sustaining treatments based on her clinical circumstances, and her family stating that Dawn Sturgess would not want ongoing treatment in the face of significant brain damage. They feel that Dawn died at home last week.
That's correct.
Yes, that's correct.
4, in our opinion, any actual or perceived delays in starting specific treatments for Novichok nerve agent poisoning did not influence Dawn Sturgess's survival.
That's correct.
Yes, I agree.
And in our opinion, the medical treatment Dawn Sturgess received at the scene and in hospital was of a reasonable standard.
That's correct.
Yes, that's correct.
Thank you very much, Professor Nolan and Dr. Soar.
Thank you.
That completes my questions for you.
Thank you. Mr. Nichols, have you any questions?
Yes, thank you, sir. I think I can do them in about 5 minutes, as yesterday. Thank you.
Well,
Dr. Saw, Professor Nolan, my name is Jesse Nichols, and I'm asking questions on behalf of Dawn's family. All right. I'm intending to direct my questions to you both, if that's all right, and you can then elect who's best placed to answer them, if that's appropriate. I hope that's all right. I haven't had the benefit of knowing the carve-up that may apply to the topics.
Okay.
So you know where I'm going. The questions relate to the information and guidance that was and was not available to hospital clinicians when they made their initial assessments on Dawn's admission. Does that make sense? And there are just two discrete points I'd like to ask you about in relation to that. Now, the first is about a risk that was considered by the authorities, including in central government, in the period after the Skripal poisoning, but before the 30th of June. Do you understand?
Yes.
And this relates to something that Dr. Dukes touched on in his statement and repeated in his evidence, in which he described in his statement there being, quote, no reason on admission to identify Novichok, and referring to the possibility of Novichok being, quote, incredibly unlikely, right? Now, the inquiry has seen, and we've brought them up on a number of occasions, various documents that show that the authorities, including at DHSE, immediately after the Skripal poisoning, had recognised the risk that Novichok may have been discarded in the local area, and there was a risk that it might be picked up and accidentally re-administered, leading to another incident. Do you understand?
Yes.
Would you like me to show you the document, or are you happy to take that summary from me? I think that's an accurate, neutral and fair summary.
It might be helpful, just
Of course.
depending on what your question's going to be.
Of course. The document is INQ 004704. You'll see page 1. It's an email thread from the 15th of March within DHSE with lots of redactions to make sure that we don't see anyone's email addresses and names. So if we just see that on the screen. And you see it refers to a first stab at the RWCS. You probably know what that means. We've heard that that means reasonable worst case scenario. And it's the reasonable worst case scenario of a secondary nerve agent incident and mitigating actions. Do you see that? Would you like
Yes,
any?
we do.
Would you
Yes.
like any further time to read that page?
No.
If I may, then I'll move you on to page 3. There's no mystery, just so you know, page 2 is a completely blank white page, so I didn't show you that. Page 3, do you see under the two bolded heading and subheadings that the secondary incident could occur in the following 3 ways that have been identified? And the second, as all witnesses have accepted so far in the inquiry, is unfortunately the awful, reasonable worst case scenario that did happen to Dawn Sturgess. Do you see that?
Yes.
Yes.
Thank you. The paper then goes on to focus on what that scenario might look like. I wasn't planning to show you that, but I know that you're thorough and may want to draw your own attention to it. If you look at the bottom of the page, do you see number 2? They spell out what that might look like. It's number 1 casualty. In fact, that is what happened, 1 fatality, other casualties and so on. And if you look to page 4 for completeness, but I'm not going to ask you about this aspect unless you'd like to look at it, there's then a series of boxes that deals with what might be done. Those are the mitigating actions that were referred to in the first page, and in particular a section that deals with hospitals and health infrastructure. Do you see that?
Yes.
Including a bullet point second that we've heard about a number of times about the knowledge and training of hospital staff about the sorts of matters we've just been talking about. Do you follow?
Yes.
Thank you. Now, we've heard that clinicians at Salisbury District Hospital were not informed that the authorities, including in central government, had recognised that there was a risk of a second Novichok incident because of accidental discovery. And the question that I want to ask is just this. Do you consider that the provision of that information, that is to say, that the authorities had recognised that risk,
Well, someone had done a first draft.
Someone had done a first...
That's all we know.
Well, sir,
But yes, you're quite right.
Thank you, sir.
That had been recognised by somebody.
And indeed, there were other documents, which I wasn't going to take you to, sir,
Yeah.
that showed the same considerations being made at other levels, including at PHE level,
Quite.
right, of the same concern, accidentally picking up a container of Novichok that had been discarded.
Yep.
And the question is, do you consider that the provision of that information to clinicians would or may have been helpful because it may have helped to raise their awareness of the risk of what was happening and inform their clinical assessment when it came to the 30th of June? Do you see the question?
Do you want me to start? I see the question, although I'm trying to understand how that would have impacted on the outcome for Dawn Sturgess.
I should have been clear. I'm not suggesting that it would have had an impact on causation. I'm asking for the purposes of the inquiry's terms of reference, including for looking forward, whether that's something that may have assisted the clinicians to have been provided with that risk information to then inform their assessments.
If I start, I think I can only say, in my opinion, it may have done.
Yes.
Because it would have raised the profile even more. Although this is a hospital that had only 3 to 4 months ago seen 2 actual cases, so their alertness, if you like, surely would have been higher than any other hospital. Whether that would have made them more alert, more wary of that possibility if they had this information, it would be speculation for me to say, but logically it would seem to suggest that that would be true.
Thank you. The way I asked Dr. Dukes it was this, and I'll ask this question then move on. He said it was incredibly unlikely to have been Novichok. And I suggested to him, well, if you'd known that there was a risk of a container in the local area and a secondary incident, is there a chance it wouldn't have been incredibly unlikely? It might have been somewhat more likely. Do you see the reasoning there? Can you see that that may have impacted on the thinking?
I can only say, and perhaps Dr. Saul will have an opinion, that it might have done. But as I say, it's speculation on my part. And as I say, I cannot imagine that there would have been a hospital more alert to that potential issue anywhere in the country.
No, I don't have much to add apart from clearly we have the benefit of hindsight here, and I agree with Professor Nolan that the Salisbury Hospital was the sort of epicentre and would have had a greater degree of alertness. And as part of preparation for this work, Professor Nolan and I have checked all our emails, and we're not that far from Salisbury and Bristol and Bath, and I picked up no signals in my emails from 2018. I may have deleted them, but of any heightened alertness in my area, which is about, 70 miles or so from Salisbury.
Perhaps I can add to that more specifically. So I work at the Royal United Hospital in Bath. We are the nearest hospital to Salisbury. We were on standby to take their, not the Novichok patients with the Skripals, but potentially some of their other patients if they had to decant. And I've checked with 1 or 2 colleagues, that's particularly the lead of our critical care unit at the time. We were not given any additional information with regards to organophosphate nerve agents in the ICU. I can't speak for the emergency department.
Can I move on, please, to guidance? And these are documents that were provided to you in your instructions. One postdates Dawn's admission and death. The other predates and is referred to in your report. Can I look at the post-dating document first? It's INQ 30657. You refer to it at page 12 of your report, but only in a very long list of documents that you were provided with. And just to orientate you while it's being brought up, what I think you're going to see, I hope, is a document that was issued by Public Health England in July after Dawn was admitted, so July 2018. I understand this to be dated the 11th of July 2018, 3 days after Dawn had died. And it's a briefing note for emergency departments. Do you see that document on screen?
Yes.
I know you've seen a lot of documents in your instructions, but just so you're aware of it. Take your time, but I don't have anything on page 1, but I wanted to show you a passage on page 2. Can I read out the section underneath bullet point after therapeutic challenge. You may want to look at that bullet point. I'm not going to focus on that. I'm going to look at the section in the middle. Do you see?
Yes.
And it reads, the most important differential diagnosis is suspected opiate overdose, and a trial of naloxone should be given initially. Colleagues should be mindful that to exclude the possibility of fentanyl contamination, rapidly escalating doses of naloxone are required to exclude mixed heroin/fentanyl overdosage. So I'm going to try and paraphrase, and please tell me if I've misunderstood this, but is this document after Dawn died identifying the main risk of misdiagnosis in a nerve agent case, that it would be identified as a dry opioid toxidrome rather than a wet one?
I mean, I think it was well established, as we've discussed earlier today, that there is considerable risk of confusion between those two diagnoses.
And is this document articulating that specific confusion as guidance to clinicians by saying this is the most recognised differential diagnosis? Watch out for it.
I think if you look at the volume of workload in the UK, opioid overdoses extremely common. I think there's something like 16,000 hospital attendances a year and many deaths. And so just on plain what you see, using naloxone is a more likely first-line intervention. And I think whoever's written this has factored that in, whereas organophosphate poisoning's extremely rare, and Novichok is, vanishingly, in most settings it'd be a theoretical concern. And you have to remember, as emergency doctors, we're getting sent stuff like this all the time. I doubt anybody would have spent a long time reading that sentence, and it's definitely not something you'd have at the bedside with you. It's sort of one of those things that crosses your email box, you read and pass on, but there's something coming out from the Department of Health or someone that you get one of these emails. I could go into my inbox today and there'll be some shortage of some drug or some new disease or something. So I think it's okay, but I don't think that would necessarily be the first document that someone would reach to. And it's mainly designed for policymakers, this, because I don't think every ambulance crew or emergency department doctor would be going to this as their first choice. They'd always be going to Toxbase. And because most doctors know opioid overdose equals naloxone, that's very well known. I don't think you'd pass medical school finals unless you knew this.
I'm not sure you've actually been asked the question yet, Mr.
Yes. No.
Dr. Thor.
The question was, and putting aside, I understand the points you make about impact and whether this would have impacted by reaching clinicians, but the question was, is this document, which is directed to emergency departments, you saw the first page, is this document seeking to identify the main risk of misdiagnosis of a nerve agent case? In express terms, the passage I just read, is that what it's trying to do?
So my understanding, having read that several times in the context of this document, is that the concept is that if you're thinking opiate overdose versus a nerve agent, then giving very high doses of naloxone could eliminate the possibility of opiate overdose or reduce it and then heighten the awareness of it possibly being a nerve agent. So if that's what you're asking, then I would have said yes.
And do you agree that that may have been relevant? It might not have affected the outcome for Dawn, but it may have been relevant on the 30th of June if that had been in place and clinicians had been aware, because it's saying to them, watch out for the most important differential diagnosis. These are the steps you should take to seek to distinguish. And that's in circumstances where we know from Dr. Dukes that he was considering both the two differential diagnoses, opiate overdose and nerve agent poisoning.
And we know that Dawn Sturgess did receive some naloxone pre-hospital, I believe. I've got that written on my...
Pre-hospital, yes. Hospital.
But probably not the rapid
And not of this
escalating
kind,
doses that you're
yes.
talking about. So again, it's speculation, but yes, it might have made a difference. Not to the outcome.
No, I understand the point about the outcome, and I hope you understand the point I've made about that.
This is a question, is it, Mr. Nichols, asking whether this kind of guidance ought to have been available when?
Before the 30th of June. I'm going to complete the circle with the last reference,
Because
if I may.
you'll remember Dr. Duke's evidence about his own attendance at events before the 30th of June where this had been discussed.
Well, he gave evidence that he went to those events.
And got the point.
He said that the issue of signs and symptoms, as I understood it, was discussed. There is no evidence documentary about those events indicating the differential diagnosis point, and that's been raised on a number of occasions, I think so, with many witnesses.
I see.
And the completion of the circle is to take you to the document that you've included in your own very helpful appendix. It's at page 130 of your first report. So page 130 of INQ 5994. And what you're going to see is what you helpfully identified as being the updated PHE document. That's 2 pages in relation to management. And I understand you to have said in your report that that update was made on the 31st of May 2018, so essentially 1 month before Dawn Sturgess's admission. And the question is this: am I right in understanding that that document doesn't include the differential diagnosis naloxone exclusion point that I just went to in the post-Dawn Sturgess death document?
I believe that is correct. I haven't read that document.
If it would assist you, I can't see it. I'm sure I'll be corrected if it's there. And for completeness, the remaining other document on this point that post-dated the Scripples but predated Dawn Sturgess is INQ 000659. I believe you had this in your instructions, so you probably will recognise the front page. Do you recognise that? You take your time. Lots of the documents look the same, but this is the one that we've been told post-dated the Scripple incident in March from PHE, but predated the 31st of May document I just showed you.
And do you have the date for it, or was
We've
this?
never been given the date, but I believe it's from around the middle of March 2018.
Yes.
Based on circulation emails that attach it. And so if you look quickly through page 1, if we go to page 2, just so you have it, do you want to look at any of that? I'm going to look at the bottom of page 3 just for completeness.
That's fine.
Fine. Can we move to page 3, please? Do you see at the very bottom of page 3 there's a line called management? If you now read through the last bullet point and then onto the next page, please. Thank you very much, Bijar. That document is almost identical except with a few tweaks to the 31st of May 2018 update. Do you see that?
Yes.
Yes. And do you agree that also doesn't contain the differential diagnosis naloxone administration point?
That's correct.
Thank you. Just one moment. No. Thank you very much. I have no further questions.
Thank you
Your
very
help.
much indeed, Mr. Nichols. It's very helpful.
I have one further question, if I
Right.
may. And this is for Professor Nolan. We discussed just before I completed my questions the issue of Dr. Jukes's reliance on what he'd been told by his colleague, Dr. Russell. And I think your evidence was that it wasn't, you thought it was reasonable for Dr. Jukes not to attend the emergency department to see Charlie Rowley.
Yes.
As Charlie Rowley wasn't going to be admitted to the ITU at that stage. And that it was reasonable for him not to read the paramedic records himself. And can I ask you, would it have been reasonable for Dr. Russell, who attended the emergency department, he was the CBRN lead, would it have been reasonable for him to read those paramedic records?
So, presumably he had some degree of handover from the pre-hospital team
Yes,
in any
and
case.
pardon me, I should have shared that. The evidence from the paramedics, specifically Ben Shannon, who cared for Charlie Rowley, his evidence was that he did a handover to Dr. Russell. He was wearing his PPE, and his evidence was that he told Dr. Russell that he had given Charlie Rowley atropine. and that is in the paramedic records.
And forgive me, because I can't remember if I've seen the document. Was that documented? Was it written down somewhere, that the pre-hospital treatment?
Yes, so there are records from the paramedics, which I believe Ben Shannon's evidence was that he handed over the record. I suppose even though things are online, perhaps they don't always work so seamlessly. So a printed copy maybe was handed over to him, and that record did include that atropine was given to Charlie Rowley.
The reason I asked is that usually there's an ambulance run sheet or a patient care form that gets handed over or copied and then ends up in the notes, so that all clinicians would then have access to that typically.
I see.
So that they wouldn't normally have to go hunting for it.
I see.
So I mean, clearly if there was any doubt about the diagnosis here, then it would have surely have been, in my opinion, the reasonable thing to do to gather that information from the
Yes.
pre-hospital team.
Yes.
So I guess my answer to your question would be, yes, I think that would have been a reasonable thing to do.
Yeah, you would expect him to take account of that.
Yes, and I have to be careful because I'm not an emergency consultant. I'm an intensive care consultant, and although, of course, we work collaboratively and our roles overlap to some extent, I can't comment on what would be completely normal practice in an emergency department by an emergency consultant. So I would just add that rider to my comment.
Yes, of course. And I should also say, for clarity, that in this case, the paramedic's evidence is that in any event he told Dr. Russell that he'd given atropine, and so it wouldn't necessarily be a question of hunting in the records, I suppose. It's whether that was said and whether he heard it, I suppose.
Correct. And I guess I don't know that, but I think it would have been reasonable to have pursued that further.
Yes, okay, thank you. I have no further questions.
All right. Well, thank you very much indeed. Thank you, gentlemen. That's all. You've been a great deal of help, and we've, I hope, understood most of it. There's no need to stay. You don't have to come back unless you want to, but of course you're free to listen or watch if you wish to.
Thank you, sir.
Thank you very much indeed. Is there anything else for this afternoon, Miss Pottle?
No, nothing else for this afternoon, but for tomorrow, so tomorrow morning we will be starting with Nick Bailey, and that will be in level 2, and that's different from what the timetable had said originally. So it's just important to
Let me make it.
draw that to everyone's attention.
Start with Mr. Bailey tomorrow, and he's 2.
Yes, level 2.
So, no devices first thing tomorrow morning then. And first thing tomorrow morning is 10 o'clock, please. Thank you.